Immuno-oncology in multiple myeloma has really rapidly exploded in the opportunity for patients and for investigators in the last 2-3 years. So we are seeing two major classes of agents, bispecific antibodies, which basically are antibodies that lead to a target on the myeloma cell engaging a immune effector cell, such as a T cell or an NK cell. Right now, the most promising bispecific antibodies, again, in the early days of this field, are BCMA, CD3 targeting bispecific antibodies. I'm aware of at least 7 of them, all of which seem equally promising. And they lead to the T cells in the patient suddenly being able to recognize and attack myeloma cells just with the infusion of an antibody that makes this meeting happen between the T cells and the cancer cells. This other part of this story is the immune effector cells, which are CAR T cells, NK cells, and the like, which are basically, again, modified outside the body to recognize myeloma plasma cells. And CAR T cells are, like, obviously the leaders in this field. We now, as of April 2021, we have a approved product. We are expecting another approval in this CAR T cell space against BCMA within the year. And we have so many other products, including the Allo7 I just talked about, that remain promising. At the same time, we are also finding there are non-BCMA targets, which are very, very effective. We have FCRH5, and we also have the GPCR5D. These are products against our targets against which there are bispecific antibodies. And again, bispecific antibodies in which appear to engage NK cells and other immune effector cells are also in development. So the field looks very, very promising. And for me, it seems very possible that within the next 5 to 10 years, immunotherapy will be the major way in which we treat multiple myeloma, moving away from traditional chemo almost completely and moving away from even some of the target agents we have right now.